Good afternoon. This is Dr. Scott Worden, the TOS guy, and I'm broadcasting live streaming actually with Dr. Art Jenkins. I'm in downtown, beautiful Sunnyvale, California. And Art, you're a continent away. How are you?
It feels that way. It's evening here, dark out. It's cold. You can see I've got my fire going in the background, at least on my computer. And here in Connecticut, it's a balmy 34 degrees.
That's terrible. I have relatives on the East Coast, and whenever it drops into the 60s, I always tease them about it. So I hope I'll message with that fireplace.
Yeah, no,
We're having a fireside
it's a metaphor. It's a metaphor.
Excellent. So we're going to try something new for all you folks who are articles from the literature. We'd like to discuss some of the current state of affairs in TOS, where some people in the field are heading now in their thought processes. So we're going to start with the first one. We're going to put up the title at the bottom. If anybody misses the title of any paper and they want to read it themselves, please reach out to us. We'll be happy to provide the bibliography. This first one is a case series. It's called A Case Series of First Rib Resection Patients Assessed with a Novel MRI Protocol for Neurogenic Thoracic Outlet Syndrome. The first author is Wiley. This was published in late 2023. Excuse me. Now, I'm going to frequently refer to my notes on this paper, so if my eyes break contact, please forgive me. Art, I'll take a few whacks at this first and just cut in whenever you have thoughts to add. One of the first things they said in the introduction is that the diagnosis of neurogenic TOS is clinical. And while standardized assessment imaging and neurophysical tests may assist in determining a site of compression, a single diagnostic test is not available. So my very first comment about that introduction is we know there's no single test for neurogenic TOS. And we also know there's really no single treatment. And part of this is something we've always discussed, right? That there's over the literature of 200 years plus now, there have been many different syndromes and many different causes. And they were all kind of lumped together in 1956 by Pete, who came up with the term thoracic outlet syndrome. But in fact, we need to be better at separating out these different causes and really different syndromes that have the end result of upper extremity pain. So while the clinical diagnosis, in my opinion, is based on a suspicion, and for better doctors, it's a stronger suspicion, there are more tests that in conjunction can narrow down this disease. So I'm trying to break that idea that we need a test that's 100%. Okay. Having said that, I'm going to go back to this paper, and they do some very interesting things. They take a bunch of patients that they've diagnosed with neurogenic TOS, and I'm going to go back through my notes here. They don't describe the symptoms so much, but what they did was an MRI technique where they elevated the patient's arms over their head, and they measured the space between the collarbone and the rib, but more importantly, they looked for effacement of perineural fat. Now, let me explain that. The MRI can show the different tissues like muscle and fat nerve separately. And when you have something that's compressing a blood vessel, like an artery, you can see that the blood vessel, which is a hollow structure, gets flattened because it's like pressing on your garden hose. But when you have a solid structure like a nerve, you don't really see that flattening because it's a solid structure. So one of the things I've always looked for in our studies is this effacement of perineural fat. The fat is perineural, it's around the nerve. It's a different color than the nerve, a different shade of gray. And if you press hard enough, you push that fat away from the nerve. And we consider that a secondary sign of nerve compression because we can't see flattening of the nerve very easily.
Yeah, so I would
So
agree
that's what they
with.
look for. And they call this a novel approach. So they call it a novel approach. And it's not really novel. We do it all the time, but I can say as far back I found as Demondian in 2007 started doing some MRI studies in France on patients with TOS. They actually did some interesting studies where they would take cadavers and they'd image their thoracic outlet. Then they would slice the cadavers afterwards in the same dimension that the MRI had used. the same plane. And they would compare them to prove that the MRI was accurate in identifying these structures, and it was. No one should doubt that. We use MRI everywhere in the body. Then they took a group of patients who had neurogenic TOS, at least by their clinical presentation, and they took people who were normal without symptoms. And they did MRIs the same way on both of those groups. And they found differences between the people who had symptoms and the people who were normal asymptomatic. So that's going back into 2007 to 2012 range. That's been done for years. Okay, but what this group also did, besides putting the arms up, which they called novel, which shows to me that they didn't really review the literature, because there's not just Demondian, there's plenty of people who have done this now, both CT, ultrasound, MRI. No problem for me. I'm glad they tried it. They also did some venograms, and to me, that's problematic in this paper. Art, I think you've heard me say before that we know in probably half of normal people, when you raise your arms over your head, these veins will get compressed.
Yeah.
And so we don't use that as a separate sign. Yeah. Nonetheless, so they did this on a bunch of patients. It's a case series. So they had actually, I think 19 patients or so and 23 operations. Some of those patients they did bilateral. And they did a chart and they gave the results. They said, the symptoms 12 months post-op. They didn't do that pre-op, though. I would have liked to have seen how many of those patients actually had improved symptoms. They didn't show that. But they took these patients who had MRI studies with their novel approach, and if the patients had reasonable clinical symptoms and they had on the MRI effacement of perineural fat, they were considered to have neurogenic TOS, and then they went to surgery. So it's a relatively brief paper, and in the end, they said that it predicted very strongly who would respond well to the resection of the first rib. Now, I love that they're using it, and I'm glad that they got good results. But they didn't do various things. They didn't take patients who didn't have effacement of perineural fat and do surgery on them. We don't know the results of that. And also, they used the venograms as a substitute for the effacement of perineural fat for some patients, and I don't think that that's adequate. So I think it's a helpful paper. I think there are some holes in it. Art, what are your thoughts on this one, if any to add?
Yeah, I think it's an interesting article. Sounds like, I realize that, and one of the things I like about the articles we've chosen is they are from all over the world. So it's a spectrum of articles from Europe, Asia, Australia, and so it's a sense of what's going on in different places. It does sound that they are maybe a little bit isolated. And one of the things that I find with most of the authors and most of the articles that we see is they tend to have a bent that is specific to their subspecialty training. Vascular surgeons tend to have, they do one or two procedures. Orthopedic surgeons tend to do one or two types of procedures. And so there's the bias that they tend to have for doing things a certain way all the time and staying in that box. And in many ways, they also may be some of the limitations you described may be to the fact that they may not have as easy access to the types of MR sequences or people who are as sophisticated as what you've been doing for quite some time, I will say. And so it's, this is a sampling, and I suspect it's a little bit of a sampling of what's going on in their local area. I was a little disappointed by the number of patients with poor response to surgery with medium or higher suspicion. I think that the standards these days for developing a pathway is to have a kind of a checklist of different types of presentations, different types of diagnostic materials. Ultimately, you want the surgeon to have the ability to choose when they think one particular type of evidence is so strong that it overwhelms a lack of evidence in other areas. But by the same token, there also you have to follow what you're doing and justify the outcomes that surgical experience and gut feeling is warranted. In the end, it has to be evidence-based medicine, not dogma-based medicine. And I think that if you don't have fairly good criteria, including potentially, striations within your criteria for what data is more valuable than others, then you're going to wind up just being like some places that everybody who comes to them gets an operation, because if you're coming to me, it's because you want X operation. So I'm going to give you X operation, whether it helps you or not. And you want to avoid that kind of trap. So you want to make sure it's a sign that they use, scientific approach rather than arbitrary measures when you're doing the analysis. And I think that some of the issues here in terms of, validating their choice of what they did and what they didn't. To your point, there's no false negative. They didn't evaluate anybody who they didn't think had loss of perineural fat. Or if they did, they didn't include them in this study. So we have no sense of what the sensitivity and specificity of their version of what you've been doing for a while in terms of doing an analysis, arms up, arms down, a true dynamic evaluation of the brachial plexus with MRI. So
they're in Australia, to your point. And yes, there were a couple things, in my opinion, they could have done. They could have taken some of these patients with a loss of perineural fat and done conservative therapy on them for longer. They had a few here, they said, that had improvement with physiotherapy or Pilates, but I don't know that they listed the length of that treatment, if it was any of the different forms of physiotherapy. Nonetheless,
yeah,
I'm glad that they used the modality. I'm glad that they started down this pathway, because hopefully they'll say, well, we've done enough of these. We're actually finding some other sign on MRI that's a helpful, negative, or positive. We only get there by doing it. We learn by surprising things sometimes. So my feeling from reading this was I'm glad that they tried to put those two together.
Yeah, no question. I just think that they need to have a little bit more rigor with either inclusion of other patients that maybe they excluded, or maybe this is just the 21 patients they had. It is a relatively small series that maybe not be borne out, or maybe there will be stronger evidence when they have a larger series under their belt.
Right. And I don't think they listed the time period from which they called these patients. 23 cases from 19 patients. Yeah, I don't think they listed how many years. So I don't know if they're a busy facility or not. Your point is good. All right. Can I move on to the next paper?
Let's do it.
All right. So the next paper, very interesting, because they had more patients. It was maybe more rigorous, but this paper drove me crazy trying to figure it out. And it's probably just me being slow. This is from Italy, and it's called The Role of Computed Tomography and Magnetic Resonance Imaging in Surgical Planning for Thoracic Outlet Syndrome, the experience of a single third-level reference center for peripheral nerve surgery. So right off the bat, it sounds like a good title. They're using it for surgical planning. It's peripheral nerve surgeons who are very detail-oriented. And the paper itself was a little more rigorous than the last one. But when I looked at the details, boy, I think the word flummoxed is the one I want to use for this. I just kept saying, wait, what does that mean? Well, how come this number isn't there? What does this number mean? So it might be a writing style difference, but I'll get into it more now. They took 107 patients out of, I think, 465 that had had surgery, and they found 107 patients who had had previous imaging, either CT angiogram, MRI of various types, or both. And they lost some patients to follow up, but they ended up studying 84 patients. And what they did, I'm going to look at some of my notes. They used CT angiography. They didn't really describe what signs they looked for, but right off the bat, and I've said this before, compression of blood vessels does not equal compression or tension of the brachial plexus. So you may have heard me folks saying something about Adson's sign. That's what Adson had. Uh, uh, he didn't have ultrasound or CAT scan MRI, but he said, well, anatomically, the artery and the plexus are close together. So if I can do a maneuver where the pulse goes away, and I assume it's occurring in the thoracic outlet, that means there's pressure on the artery, and therefore there may be pressure on the nerve. We know that now there's very little correlation, if any. And as we were just talking about, 50% of people who have their arms over the head will have compression of the veins. But today is not the 1920s. Today is the 2020s, and we have MRIs, we have ultrasounds and CAT scans. So the CT angiography is very interesting to me because you don't see the soft tissues very well. You see the bones very well, and you see the contrast in the arteries very well. But I don't know that it shows the compression of the nerves, which the vast majority of these patients are obviously neurogenic. So that's one thing that started me off, that they had several patients with that. Then they used patients who had had a brachial plexus MRI. And if I can find the language here, they included a whole bunch of other things. The broad term, I'm quoting from the paper, the broad term brachial plexus MRI also refers to cases where brachial plexus neurography, that's pictures of the nerves, and arterial and venous vascular angiography MRI sequences were completed. Now, I don't know what numbers those are. I don't know. Does that mean that these were in addition to a real brachial plexus MRI? Does it mean they were instead of? So, right off the bat, there's heterogeneity in this, and this is clearly not written by a radiologist. I don't see a radiologist involved in this from my gut feeling. The brachial plexus MRIs that Art has seen, and most doctors have seen, probably everybody shrugs their shoulder at them. It's not the brachial plexus we need to look at. It's all the things around the brachial plexus. This is changes that occur when we move the patient's arms. Okay, so they took the patients that had had surgery, and they started out with patients who had had anatomic abnormalities at surgery, group 1, and compared it to group 2. And then they went back. There's a retrospective study, meaning you're just gathering old data and collating it and assessing it. Then they took those patients who had either had or had not anatomic findings at surgery, which we'll call the gold standard, and they took the CT angiogram and the MRI of various sorts, and the combined group that had these imaging, and found how many of those had anatomic abnormalities. And the way I'm describing it to you is about the way they described it. I don't know which anatomic abnormalities they saw. There are, as we just discussed, many causes of neurogenic TOS: fibrous bends, cervical ribs, soft tissue masses, abnormal pathways of the brachial plexus, costoclavicular narrowing when you raise your arms, changes the pathway of the brachial plexus in the retropectoralis space, subclavius posticus muscles. There's a number of them. And so I don't know what they're correlating. But in the end, they put these charts out that are just gross numbers and percentages, and I had trouble figuring them out. And I got two things from that. One is, as they said in their impression, they did better results when they used both the CT angiogram and the MRI results together. And that meant that's group C, subgroup C. Subgroup A is just CT angiogram, subgroup B, just MRI. Subgroup C is those studies combined where they found an abnormality in one of those, not both. That opens up the door to, was it real? Could you see one on the other modality? And again, it's just a broad, I don't know what the anatomic abnormalities were. The other thing that stood out was they had a bunch of patients, group 2 in surgical groups, where they found no anatomic abnormality. So of 84 patients, 46 at surgery had anatomic abnormalities, and 38, nearly half, did not. So now you have to say, was the diagnosis accurate? Because when they went to surgery, they didn't find an anatomic structure. However, I got to go back a bit. Earlier in it, they said the second group, those that at surgery had no anatomic abnormality. They said the second group included patients with postural abnormalities or with acquired traumatic and functional causes. I don't know what that means. Do they mean that group 2 had no fixed anatomic abnormality, but that their rib and clavicle got too close together, postural abnormality? Or do they mean acquired traumatic? Do they mean a callus of a fractured clavicle? So I don't know what that means, and I have trouble with this paper trying to interpret that. Uh, Art, any thoughts on that?
Yeah, actually, so this is an interesting. So it's a single site. They don't say what the site is, but it's clearly a place that draws people from all over the continent of Europe to come get their TOS operated on. As you said, there's doesn't seem like there's any hard and fast rules as to how they do what they do and who they choose to do it on. I was shocked by the fact that 40% or more of their patients that they operate on, they didn't find anything at surgery. And I'm equally shocked that basically only half of the ones they found something at got better, and almost none of the ones they didn't find. I mean, that says to me that we're looking at 70% of their patients didn't do well with this procedure. At least that's based on their outcomes, but their outcomes are so vague and non-specific as to what they were measuring. I'm a little surprised that this is one of those articles that if they had just stopped at the evaluation and not talked about the outcomes, it would have been incomplete, but at least it would have discussed opening the door for finding anatomic issues. And I think that they're hinting at that with the C group being the best outcomes in terms of the longitudinal, the post-op outcomes. But it just, to me, it's a very, it's not the type, it's not this type of series I'd be happy to be publishing. Although in many ways, these are the types of series that should be published, even if as a cautionary tale. It's, I have no problem saying the TOS surgery is challenging. Finding patients is not hard. Finding ways to make them better requires a lot of care, and not offering them an operation that won't make them better is sometimes the most important thing you can do. And so it's, to me, this is, I'm glad that they're raising the specter, that we should be in an era where CT and MRI are much more universally available. I know how you feel, Scott. I certainly feel the same way. In general, my preference is for the non-ionizing radiation before the ionizing radiation. I will say, at least here in America, sometimes the problem I get is the insurance company just won't pay for an MRI. But they often will pay for a CT angio. And that's, to me, seems crazy, but that's sometimes the way it works. And, there may be, some of these patients in Europe. I mean, I know some of the authors is from Slovenia, another one is from Switzerland, another one is from Italy. And so there may be a lack of access for some of their patients to this, but I would think that at the tertiary center that they would have access to all three or all the modalities that they need prior to surgery. It's, I don't, maybe I'm biased because I have such, great radiologists to work with to query the patients and get to an answer more definitively. But I generally don't operate on somebody unless I see a clear connection between the radiology and the physiology, that they have all these provocative tests, and whether it's, Adson Roos, East, and the various points of pressure and percussion. But I've got to know that there is an anatomic finding that's consistent. And so the arms up, arms down. I mean, as you know, I keep going back to my little model of looking at, what the brachial plexus looks like with the arm up and the arm down. And to me, if I don't see this either on MRI or CT, um, I'm much more reluctant to go in. And I know vascular surgeons have no problem operating without imaging, other than maybe an X-ray to prove they don't have a cervical rib. And to me, that was great back when you didn't have access to MRI. But in this day and age, with if you're looking at a 70% failure to adequately respond rate, I think there's got to be a better way of doing it. And I think that the onus is upon the surgeons to look at these results with a very careful eye and say, we can either make it a free market and just, if patients want the surgery, we'll offer it to them, or they can act more like physicians and less like businessmen and say, this is not the operation for you, or it's not for you yet until we prove or feel we have a higher likelihood of not guaranteeing, because there are no guarantees in surgery, but of providing a high probability of improvement with this intervention.
So just like the previous paper, I applaud them for the work they put into this, for using different modalities. It is a retrospective study, which means that they didn't have the choice to offer it at the time. Whoever made the decision, we're not saying that now they're not making that decision. Again, the point that a lot of the patients they operated on didn't have anatomic abnormalities to explain the syndrome is a cautionary tale, to use your words. And there were a lot of MRI and CT findings in the patients who didn't have anatomic abnormalities. So that group 2 troubled me a bit. And the fact that there wasn't a big differentiation between the imaging findings on the surgical patients with abnormalities and the imaging findings on the patients without abnormalities. So I would have said, if I were involved in this group, they seem like diligent people. They need a radiologist to look at what was found. Why didn't they say, at surgery we found these 3 things? Can we see those on MRI? So if they were there on the MRI and not found by a radiologist, that would seem to increase the likelihood in the future of using imaging properly. We do that all the time. When I'm doing my regular radiology work, Art, I'll see a discrepancy. I'll read a CT and maybe the fellow or the gal on the previous report didn't mention something that was there. So we have a mechanism to feed back and say, you should know that there was a small adrenal mass, or that there was a fracture. You listed the wrong vertebral body. That's supposed to make us better. And I don't see that on this paper. I understand it's asking for a lot. And they have
Well,
other
as you
things in
said,
mind.
this may be, after when they look at the conclusion, this may be them edging towards creating a new standard for how they do it. And I certainly hope that that's what they're going to do with this. It's interesting. They did not include any of the evaluation with injections or with other types of the evaluation modalities. So I think that, to me, the real cautionary tale is here, that even with the imaging, and frequently they didn't find, but if they were more likely to find something at the time if they used imaging. And I'm hoping that led to more indicated patients getting procedures, and maybe some of them being held back for
That's a
more
great
imaging.
way to put it. So their patient selection to go to surgery could have been better theoretically.
I think anytime you have a patient who comes out without a benefit from surgery, that surgeon is obligated to think long and hard about how he put that patient on the table and what their indications were, and what he can learn, he or she can learn from how they got to that point. Was it a failure of technique? Was it a failure of indication? How do you get there? I'm not saying that it's every time a patient doesn't improve is a failure of, a terrible thing has happened, but we really, in this day and age, with scientific method, we really should be seeing high probabilities. They should be rare, And that makes it even easier to focus on what can we do better on this shrinking group of patients who don't have an adequate response to the intervention.
But diagnosing neurogenic TOS is by its nature as a disease tougher than diagnosing diverticulitis.
No question. And that's why the standard has to be higher for
Right.
what you do to get them across that surgical indication
And
line.
it's not a low-hanging fruit. We need to work together. You know, how many times do I ask you questions about how you see things? I need to be better at that. I'm not a surgeon. I never will be one, but I need to understand what questions you're asking. So, what is it that you do that I can play a part in? And for both of these first papers, I don't know how much involvement they had from a radiologist. I would
Yeah,
certainly hope over time they say, well, we see some value in it. We published it.
yeah.
Let's get one of our
It's,
radiologists to buy in and work with us like
I,
you
I
do. And
suspect I suspect that this was a case of patients who came with them. They looked at it, and I'm
possible.
hoping that having seen this, they are now requiring it, and more proactively. Maybe they will be talking to someone like you, like I do, to say, "Hey, how can I order this test best to answer the question
Yeah.
I'm asking? How can I
Yeah.
be proactive and require this study prior to even seeing me in my office?" I mean, as you know, there are some patients who are getting their NeoVista MRIs before I've even seen them, because based upon a preliminary evaluation, it sounds like it's a high likelihood, or they've seen another practitioner who has preliminarily diagnosed it. And I will make sure that so I have everything at my fingertips when I'm seeing them, rather than wasting time, especially if they're traveling a long distance to come to this tertiary center. The more
Right.
proactive they can be, or if they
Great
can
point.
do it on site, then great.
So your point completely well taken. Some of these patients may have shown up at this third level referral center and said, "Here, I've got a CTA with me." What that means to me as a radiologist, what maybe a lot of, I know not you, but a lot of doctors don't realize, just get an MRI, just point the machine at the general area like it's a Polaroid camera. I consider myself more of I'm not Ansel Adams, but that I pay attention to detail to that level. And so, if you as a radiologist hear that patients are bringing in their outside studies, it could be any number of techniques, any number of things that you can see and can't see because of the choice of
Not
technique. So,
not to
putting that
mention
into a paper
quality.
like this, and the quality is different, different machines, different
Yeah,
technologists. That's right.
yeah.
So, when
0.3
you add
Tesla
that
magnet
data,
versus a 1.5, one that
right,
hasn't been tuned properly to one that has.
it's like if you know anybody who collects stereo equipment, even if you own a 3T magnet, you can have all different levels of software and gradient coils. But what happens is you get this junk in, you get this varied technique that shows all these different things. How do these surgeons who are diligent, trying hard to make something new, how do they count on that imaging data? When we read a paper later, we're going to look at description of different surgical techniques. Have you ever seen a paper saying we did surgery on 300 patients? Some got transaxillary with two surgeons, some got supraclavicular, but one guy had to leave the room. You would never accept that paper. It's one technique and it's uniformized. You want to get rid of as many variables as possible if you want to get to
Or
your data.
or or
So they may have
or
had
you wanna
difficulty
make sure you
selecting the
have
right
enough.
patients because their outcomes weren't.
You wanna make sure you have
So
enough
anyway,
N in the
I like the
subgroups if you're
paper.
gonna do that.
Yeah, which means way more patients and way more data points. It's just hard to get that many patients in a disease like this. So again, I'm glad that an imaging center is looking at advanced imaging. Sorry, glad that a referral center is looking at advanced imaging and trying to correlate it. And hopefully their next papers keep improving. That'd be great. Our next paper is Surgical Approaches for Thoracic Outlet Syndrome, a review of the literature. And the first author is Suzuki. Art, you want to start out with your thoughts and points?
Sure. I mean, this was a straight review of the literature, so this is not there's no personal experience here. This is just a general concept of what, let me just pull it up here. That's the article. And so this is a Japanese tertiary referral center. They're hand orthopedic surgeons, so they probably do, and knowing as I do sometimes in Japan, they tend to be there's one style that they do, and they practice that one style, and in a relatively they perfect the one style, put it that way.
The,
And
the opposite of what we were just talking about.
right. So, but this isn't their personal experience. This is their general review of the literature, and they're looking at a bunch of different, all the different approaches, going back from historical to current. They lump a few of them together, and then they actually, I was a little hurt. They missed my article in their review of the posterior approaches on my MIS cervical rib technique, but that's okay. We won't. In the neurosurgical literature, we would call the posterior approach a parascapular approach. It's a little different name to it. And then they reviewed from the review of the literature that they had, and it was a fairly short review of the literature. I mean, there was only 20 articles that they referenced, which seems a little light on the a little selective on the review. And so, for example, for transaxillary, although it was a systemic review, those systemic reviews are less specific. And then for the infraclavicular approach, they used a small single surgeon case series, which is a very limited slice of the literature on the infraclavicular approach. So it's a very lightweight review of the literature. It is more of a general introduction to the different surgical approaches rather than a comprehensive review of the literature. And so, they try to discuss complication rates from these very limited number of series. But the problem is that the complication rates in those original articles are described very differently. So it's more of an apples and oranges type comparison. I thought that probably the most interesting aspect was that they used different diagrams to show, the different types of approaches, which are, nice for the surgical group, but for people who are trying to understand what this means, who aren't specifically already surgeons, they won't be very helpful. And for those who are, it's too general for their purposes as well. They very nicely say that each approach has its advantages and disadvantages, and that surgeon skill and selection is necessary for good outcomes. And that wasn't really terribly exciting result. It is, so I think the most interesting thing in here is that their own personal take on this was really just in the table 1, where they talk about the advantages and disadvantages of a particular approach, which actually is the tell of their particular bent and preference. Because as you read into what they talk about are the advantages and disadvantages of each approach, you can see why they choose the ones that they do, because of the way they describe them. It's, as I said, it's a very lightweight review of a very broad subject, that probably, got to be too big a project to kind of dive deeper into it. I almost would have preferred that they had broken it up into a couple of different articles and really dove deep into, the 3 biggest, which are the transaxillary, the infraclavicular, and the supraclavicular, and leave out some of the others because those are the posterior, as they say in their experience, it's used primarily for revision. And as I said, with mine, it's for the cervical rib resections, because so those are a different entity. And so it's more of it's just not enough and too broad. They took a shotgun to the approach instead of, a couple of clean shots.
Great. Yeah. Yeah. Reading it, they had some nice historical points in there, like mentioning Adson doing a scalenotomy, which fell out of favor. They talked about Claggett's posterior approach, which is very different than yours. He had problems. He was president of the American Thoracic Surgery Society. Anyway, at his presidential speech, he encouraged research on TOS, but I think his posterior approach, correct me if I'm wrong, really led to a lot of muscle weakness and fell out of favor quickly. What you do is a very more
Well,
narrow
what
approach.
his posterior approach likely resulted in significant traction and pressure on the nerves as part of the approach, and and that's why I don't use it other than minimally invasively for cervical ribs. And I tell those patients with the caveat, if your cervical rib is huge and I can't get to it from the back, we may be coming back from a different approach rather than hurt the nerve. We're going, and that's the other advantage that they talk about the review of the literature, but they don't describe any of the differences in techniques. So one of the things that you and I have talked about before is that intraoperatively, as a neurosurgeon, we tend to monitor most of our patients' nerve function while we're operating on them. And a lot of specialists don't, either because they haven't really made it part of their routine, and it's inconvenient to order it and to arrange it, and they may have to bring an outside company in to do it if they don't have it in their facility. And it slows down the case just a little bit because you have to wait for them to set up before you start. Make sure you have good potentials before you start. And then if periodically somebody may tell you, stop what you're doing. And some surgeons don't like to be told to stop what they're doing. So and so to that point, if I'm ever encountering those things, I'll change what I do. And that's not something they had 40, 50 years ago. And that's part of that evolution we're seeing in these, and why some approaches can be, brought into the next millennium.
I personally found it interesting to read. It was a nice review of the different structures. As you said, it was not meant to be a heavyweight paper. I think it was pretty nicely written. I had a few disagreements with some of their assumptions. They made some statements that I'll give you an example. Scaling, quote unquote, scalenectomy directly decompresses the nerves or prevents elevation of the first rib up to the clavicle, which I have never seen any supporting evidence for that.
Yeah.
I know
Yeah.
scaling muscle blocks are used a lot, and some people say it's because it'll allow the first rib to drop, and I just don't buy it. Let me see some data.
It's
Nonetheless,
not that it's not the first rib that drops. It's the clavicle that comes down because of the injury to the muscles that support the scapula. It's the first rib's not, except in very rare occurrences, the first rib isn't floating around, running around, being like a loose cannon on deck. That first rib is just part of the thoracic cage, and the arm, if the supporting muscles of the scapula are damaged in some way or weak in some way, then when that will draw that clavicle down, and then it may put the tension on the scalenes. So there are just so many other reasons. I will say that, routine use of scalenectomy in lieu of first rib resection, I think that's one of those procedures that you wouldn't just do it on every patient and do nothing else. With the knowledge and the great MRIs that we have that show that there's other problems going on. But I just did a college baseball player recently whose only problem was scaling compression responded great to scaling blocks. We did a surgical scalenectomy and he did great. So it is a limited procedure for limited but very specific indications. I don't think it shouldn't fall out of favor for the right indications, but it should fall out of favor as the preferred way of doing it.
Well, interestingly that you brought that up, my next point was if you look at table 2, they compared supraclavicular scalenectomy with first rib resection
Yeah.
to supraclavicular scalenectomy without first rib resection, almost
Right.
the same number of patients, and
Right.
no first rib resection did better than with a first rib excision resection. So I don't think that's true in general, but
Yeah.
then again, I don't know many people who go in and don't do a first rib resection.
I would say the only way that would work out is if they used the same indications I did. It was purely scalene compression without first rib compression. No information about that here. Once again, it's
Right.
this is just, it's a very light passover of a very broad subject. So, it's useful for someone to read to find a couple of the articles on a subject, but it's not a comprehensive review.
Let's go on to the last paper we were going to discuss. General overview and diagnostic parentheses imaging techniques for neurogenic thoracic outlet syndrome. I don't know why they threw the word imaging in there and then put it in parentheses. This is a group, Tajink.
Don't take it
I'm probably
personally, Scott. Don't take it
mispronouncing it. I
personally.
apologize. So Tajink, Pesser, Goten, these are some people in the Netherlands who have published several papers recently, and it's very interesting. I have some likes and dislikes about this paper. I'm going to actually let you go first, and then if you didn't cover stuff that I had in mind already, I'll throw in a few thoughts.
Yeah, I mean, this is mostly the Dutch group, and I suspect that this was somebody who had trained with them who went on to the U.S. The one U.S. author in our group today. So go USA. So they talk a lot about NTOS.
Actually, that's interesting. So I'm looking through this. I know Hugh Gelibert, very experienced, very nice man, vascular surgeon at UCLA is here, and he's listed. The other authors, I don't think any of them, sorry, are in the U.S. Yeah, as I look through the authors.
So, they talk a lot about NTOS, focusing on those that already have atrophy as a major component of NTOS. And while I know that historically had been, in fact, as we know, it wasn't real TOS until you had atrophy. And obviously, those of us in the business, our goal is to treat patients before they get to atrophy rather than, hold off and wait and say, hey, is it atrophic yet? If it is, okay, then we'll try to fix it. It's literally like saying the car is rolling down the hill. Should we put the parking brake on now, or should we wait till it goes over the hill and then try to fix it after it's smashed? But it's so they spend a little bit of time talking about the Gilead summer hand, which is a nice little vignette, but one that, in our practices, we don't want to see. And then, they have their pathway for looking through. I like the fact that they do require an x-ray to rule out cervical rib. Goodness knows I've seen that a number of times on my patients. That's been missed, and I pick it up. So they have a number. They describe in nice detail a lot of the physical exams that people go through. It's certainly it's a diagnostic article, and I'm delighted that they discuss in great detail much of the physical examination findings. I thought that I had a feeling that you would probably be amused by the fact that they spend more time discussing high-resolution ultrasound than they do MRI for TOS. And in terms of the fact that they do have a multidisciplinary group that gets together. It's nice that it's not just one surgeon saying, "Yeah, I'm going to cut you open," and there are a few people that go into it. I was interested because when you look at a bunch of the different articles that we talked, and they talked about the response to conservative management and physical therapy. I was actually a little bit surprised by the rate of response to physical therapy that some of these people describe. And part of that may also be my personal bias. As you know, there's not a lot of wisdom about TOS therapy for patients with TOS, and how important it is to understand the different causes of TOS when designing a therapy program. 17 different muscles that support the scapula. How do you rehabilitate every patient the same way? You can't. And that's why so many of my patients come to me and said, therapy made me worse. And that's because of the 10 or so exercises physical therapists tend to do. They 7 tend to make them worse. 2 probably have no impact on the TOS itself. And 1 may help. But the net is they got 7 bad and 1 good, so they're net bad on the PT experience, and so it's the PT program that they would use for preoperative, because they required preoperative PT a certain time in PT before they would consider a surgical candidate. That if they could have characterized that in a little more detail, because that's, to me, that would actually be more useful than a long description on the physical exams that in this day and age anybody can Google. So, and then they do talk a little bit about the different neuromuscular blockade, and using those, using the testing, and so I'm happy to see that they are at least looking at it as a systematic approach, and that they are requiring post-op rehabilitation. And so I like the general direction they're going with this. I hope they understand that this is an iterative process, and this is version 2.1, and that they, ultimately we all want to get to version 9.9. Where we validate the data that we're using and have the most advanced imaging, injections, therapy, intraoperative neuromonitoring, postoperative rehabilitation that targets, that is patient specific. So this is a start. But as I said, I can only imagine where you're going to go on the preoperative workup that where they spend 50% of their description on the physical examination, and 1 paragraph on MRI.
Thank you. It's great to hear your points on that, and I agree with everything you're saying. Parts of this paper I really loved: the physical exam, the provocative tests, where they set up this apparatus to do the EAST test in a uniform way. Right? They put the patient's hands up on these bars that have squeeze pads of sort, and then they measured the grip strength, and then they did it before and after scaling muscle block. Those things are all reproducible. They're all precise. That's great. We don't know the value of those things. What they don't tell us is what's going on anatomically. None of these tests that anybody uses to diagnose neurogenic TOS tells us what's going on anatomically. And we've known this for 200 years. There have been different causes of this. So they spend all this time on the physical exam. That part was great. Really, just love it. Gold star. And I wish more people would do that. There's a guy named Dick Braun, retired hand surgeon in San Diego. And he used to do something similar where he would measure the work that a patient could do before and after a block. Okay. Now, by the way, we don't know why that occurs or what that means, but use it. Okay. Use it and we'll figure it out over time. But here's some issues I have. And you were absolutely correct. The way they approached imaging feels to me like they didn't have a qualified radiologist involved. Hugh Gelibert, one of the authors, really nice man, really sincere, really helps patients, tons of experience. He's not a radiologist. I'm not a surgeon. I would never advise him to do things. And I try to understand what surgeons do so I can be better at what I do. And I think this is a collective theme of what we have today, that we have these tools and we're probably not using them correctly. We're not using them consistently, the same technique. We're not answering the same questions with them. Certainly, they're part of the answer. They don't have to be 100%, but that's kind of the standard some people put on them. So here's a sentence, a quote. The etiology of the compression of the brachial plexus is controversial and not completely understood. Unquote. That's BS. We know the plexus gets compressed or stretched. It's like every other entrapment neuropathy. It behaves the same way. But then they go on to list a whole bunch of things that may cause compression. They consistently talk throughout this about finding compression. So I don't understand why they had to mention that it's not completely understood. Maybe 5% of patients have something unusual. That doesn't matter. The vast majority of patients have compression or tension on the brachial plexus. That's what we're addressing. Okay. As you said, they spend a lot of time on the Gilat-Sumner, however it's pronounced, Gilat-Sumner hand, which is, for everybody who's listening, when the nerves get so damaged that the muscle fibers, the largest central fibers that are myelinated or insulated, when they get damaged and you start losing the muscles in your hand. And at that point, as Dr. Jenkins said, you can't, the cow is out of the barn. You can't regain, in most cases, the muscle strength. So every reasonable doctor tries to find an entrapment neuropathy before it gets to its end stage. So they mentioned Gilat-Sumner hand. They give a really neat example, this wedge sickle sign on ultrasound. That paper came out and it was interesting, but it's used in this tiny fraction of patients. We have this huge number of patients with neurogenic TOS that don't have muscle atrophy in the hand. Those are the ones we want to be accurately diagnosing, promptly diagnosing, and correctly treating. So great, they showed a sign of a wedge sickle sign, an image, but they even then mentioned that it's really only useful in this rare case. So I don't understand why to spend any time on that. Then they have this section on neurogenic TOS without signs of Gilat-Sumner hand. And they use the Society of Vascular Surgery reporting standards that I brought up before. I know you've heard me say it, Art. For venous TOS or arterial TOS, this SVS, Society for Vascular Surgery, they advise all kinds of advanced imaging, ultrasound, CT angiogram, MR angiogram. When it comes to the 95% of cases that are neurogenic, they say get an X-ray. And in the radiology literature, there's plenty of supporting stuff. The things that we can show with an MRI or a CT or with ultrasound, there's tons of stuff out there, and they just don't seem aware of it, or they seem like they're intentionally excluding it. The few times they comment on it.
Look, the SVS is a vascular surgery support group, essentially. It is, they are an advocacy group. They're part of, that's made up of vascular surgeons who don't want to change what they're doing. So that's validating, yeah, keep doing what you're doing. We're not going to change what we require.
Remember, I was involved with that group, Art. I was involved.
I know you were. I know you were. And I don't want you to reveal any confidential information if you had a non-disclosure that you had to sign. But it is what it is. And when you get a bunch of vascular surgeons together to decide, well, should we make the criteria more stringent for doing this procedure and have you do fewer surgeries, or less stringent and let you do as many surgeries as you think is appropriate based on your clinical judgment without necessarily having radiologic confirmation of what you're doing. It's like being in Congress. You can't get stuff passed if there's too much special interest opposing what you're trying to do.
They don't want any stinking radiologists telling them their job.
Well, yeah,
So
I mean, and they're not listening. It was everybody got a vote, but yours wasn't counted.
true. So they list these criteria, which include local findings like pain, tenderness, peripheral nerve findings, the absence of other diagnoses, and then the positive anterior scaling block or pec minor scaling block, which, by the way, are two really different things. But
Of course.
then they find all these reasons why imaging, imaging may or may not help. I don't know. Yeah, we've looked at it, but then they just say it's a diagnosis of exclusion. You could do an MRI to make sure there's no cervical spine
How
disease.
can you exclude if you haven't imaged?
Well, but that's the way they justify the imaging. When you do use imaging, it's a diagnosis of exclusion. And I don't buy that. The radiology literature doesn't buy that. I've done more cases as far as I know than anybody in the world. And I'm not looking there and saying, I don't see anything. I'm looking for the things that every doctor wants to know. Is this a cause? Is this a contribution? Is this an etiology? So they talk about x-rays, which I think are of very little help. As you said, you could rule out, cervical ribs. The SVS says, look for,
Cervical rib, fractured clavicle, a diastase rib, a rib fracture, first rib fracture. Those are the types of things you're going to see on an X-ray, and that's like 1 to 2%.
yeah, they don't, I don't even know they say fractured clavicle. They say 3,000 cases I've seen, 1/10 of 1% have cervical ribs. The vast majority have soft tissue abnormalities, fibrous bands, abnormal dynamics with it. So this paper, they spend some time, they do at least describe imaging tests, and they do give some reference to the fact that you should do it dynamically with the arms up. But they just really don't see it as contributing. And then they go on after that, and with the same lack of data the data they ignored for imaging, they don't have any supporting data, but they say scaling blocks can help. I still want to hear the explanation for why that makes a difference. Where's the test that shows patients with negative scaling blocks do worse at surgery? Okay, I don't see any of that. So having said that, I feel like they're biased against imaging, creating an impossible standard for it, and are unaware of the literature. They haven't consulted a radiologist to see what could be out there, because that's our field.
Are you
And
offering
then they use
skills?
the scaling block. Well, I would. I was involved before. I'm like you. I want to see things get better for these patients. But you know what? The other good things I want to say, because I don't want to be too negative, they did have a multidisciplinary group. It was kind of managed initially by physical therapists, which, while I don't know what technique they're using, it's an interesting approach. They did include 2 radiologists, they said, but I don't know if they're just reading cervical spine x-rays, because it didn't seem like there was much here contributing. And as you said, the post-op rehabilitation program. So overall, my feeling was they did build a structure. I don't have to agree with it, and I don't think they care if I agree with it. But as you said, it's an iterative process when we talked about the last paper. So if they have a structure in place and they keep their eyes open, they're going to gather data over time, and eventually someone's going to say, we can make the program better by doing B instead of A. And those are all really good positives.
Yeah. And who knows? Maybe people will look at this article and give them feedback that's similar to what we're giving. I'm not trying to be critical for the sake of being critical. I think these are the thoughts I have when I see this, and I love looking at other people, what other people are doing, and saying, what can I bring into my practice next? What can I do? What can I take out that's not as useful? What can I put in that will actually add value to how I evaluate patients, value to the evaluation. And so, these are thoughts that we're kicking around, and helping hopefully some viewers out there to understand how they would evaluate the evaluators themselves. Who's got a system that works, and I have mine that I use, and it does involve heavily with the radiology. I will say, a little plug for for my colleague who's put his whole life into this endeavor, and greatly appreciated what he's been doing. But it's you've got to make sure that the clinical, the radiologic, the interventional, the history, and the outcomes afterwards are all strongly correlated. It is a constant iterative process, and in many private practices, the team to go do that iteration, the review, the research team, it's just not there. It's not robust, or it's not adequately funded, because the at hospital department and practice administrators often look at research as fluff, as wasted profit, as money that could be put towards other resources. But it's that iterative process that improves the product that is the value. And to me, I mean, I just, when I went private, the first thing I did was hire a research coordinator and a research assistant to help me, so that I have multiple eyes looking at everything, and sometimes they come up with great ideas that can help us too. But it's to make sure it gets done, and we reiterate it and reiterate it and revise it and say, okay, well, you know what? We figured this out. So now we're not going to do that anymore. We're going to do this instead. And so there are definitely some major changes I've done both in TOS and non-TOS research. And we have about 10 different active research projects that we're working on at any given moment, from this top of the spine to the very bottom of the spine. And TOS is one of them.
You're actually giving some lectures on a couple of other syndromes at the other end of the spine.
As a matter of fact, I am. I'm actually talking about the use of amniotic tissue membranes in spinal surgery, as well as craniocervical instability that is treatable to manage signs of autonomic dysfunction. That's a talk I'm giving in a month. Two very different subjects, very different from TOS, very different from some of the other conditions that I'm also known for.
Like Bertolotti's syndrome.
Like Bertolotti's syndrome. And so it's, there are challenges, and we can either get really good at doing what we've been done for the last 40 years. And then we'll be like, I don't know if you've ever seen the movie Other People's Money. Danny DeVito, Cary Grant, Rene Russo, great movie. And, they talked about how back in the 1900s, all the cars used all the horse-drawn carriages used buggy whips. And the buggy whip manufacturers were making money hand over fist. But as the cars came about, the horse-drawn carriage got phased out. Those buggy whip manufacturers started, first they would consolidate, and then some would just go out of business. And you can bet that the last buggy whip manufacturer probably made the best buggy whip that they could. But other than maybe the Amish, nobody uses buggy whips anymore. So you got to evolve, and you've got to adopt new technology, whether it's radiologic imaging or minimally invasive techniques or intraoperative neuromonitoring or preoperative. One of the things we're looking into is preoperative SSEPs as a test to identify TOS patients, similar to radiology, in a position of function. Checking SSEPs, arms up, arms down. Is that a way that we can pre-screen better for NTOS? But whatever it is, we're not sitting on status quo, because if you're treading water, you're getting swept downstream.
Right.
No matter
how 3 of these
well
papers, in my opinion, just could be used, and they probably don't have a team that they work with. I think this and other literature supports the fact that TOS is clearly not a low-hanging fruit. Say this all the time. Clearly needs multidisciplinary approaches, which his last paper did, right? They got a good team. But hopefully when they For instance, I'm selfish, but when they have radiologists, I hope the radiologists are just not reading x-rays. I hope that the decision makers are saying to the radiologist, what can you do that's new? What can we try? So I think we've proven that neurogenic TOS is you know, one tough disease to diagnose, and we can all do better. And that's why I work with people like you Art. 'Cause ever since I've known you, you ask me way too many questions, especially all the ones I don't know the answers to, which is most of them. And then I have to go and
Listen,
figure out
every
something.
good answer gives you 2 new questions,
Yeah.
at
But
least.
the end result is we're better. So I appreciate that very much in our collegial response. And we're talking about a journal club in New York City. That'll be even more fun with all the academic people other than you. So thank you for your time. I really appreciate your input. This is a great idea.
I did see we had one question on the
Oh,
comment
good.
board.
Huh.
Um,
Smoothie says, I love this channel. The videos are so helpful. I only have TOS on the right side, but feel like it's also on the left side. Is that normal? Art, how many people do you know that have asymmetric bilateral TOS?
oh, lots of them. In fact, interesting as you know, Scott, a lot of the patients we see radiologic findings on both sides, even if they only have findings clinically on one side. And then there's so many different variations on the theme. Some people have they might have had an injury on that side, and that's predisposed them to having this problem. Another thing that's very common with TOS patients, there's a high incidence of hypermobility syndromes
Hmm.
in patients who have TOS because they're more likely to injure that shoulder from their hypermobility. And frequently that hypermobility has led to almost a superpower like ability when they were younger, whether it's pitching or gymnastics or
Right.
swimming or doing butterfly or maneuvers that would be otherwise difficult to do for the average person. This hypermobile person has that ability, but by the same token, when they get older, the damage is often accumulated on that dominant arm. But also, there's patients who we operate on one side and the other side gets worse. And then there's patients we operate on one side and that other side feels better. There's so many
Hmm.
complexities to the bilaterality of TOS, and that each one is different, but we do know what to look for, and that's why when I examine patients for TOS, even if they have one side symptoms, I always
On
examine
both
both
sides.
sides on everything because you just never know.
What is your best educated guess? Take a patient who's got unilateral symptoms. You operate, they do well. And then 6 weeks later, 2 months later, they start developing symptoms on the other side. Why do you think that occurs?
Well, I think some of it is that during the postoperative period, we limit the motion of the surgical side, and um, then so they, while they were focusing solely on the other side, that kind of worked themselves towards a potential injury, like a repetitive stress injury on the shoulder joint and the shoulder and the brachial plexus. I think it's also there. There may be some post-op scarring in the surgical field that can lead to alterations in the venous flow, and then that can lead to relative obstruction of venous flow through the collaterals on that side. They shunt around to the other side, and those collaterals blow up and then cause compression. And I've talked with one of my colleagues about this extensively, who's kind of like the venous vascular surgeon guru, Dr. Windsor Ting. Shout out to him. And he and I have talked about all the different collaterals and the impact those collaterals have on the development of symptoms, both improvement and worsening. And so that's, I think, part of it as well.
Thank you. Smoothie, I hope we helped with your question. Thank you for the compliments. We appreciate your contributions. Tate says, Dr. J, could you speak more on what is your checklist to determine a surgical approach is appropriate? And very grateful for these talks. Thank you, Tate.
So I think that when you're looking at choosing a surgical approach, for me, and I think some of it is surgeons tend to be biased towards the procedure that they know how to do well. And that's not to say we can't go out and learn new techniques, But from my reading of a lot of the literature, I don't see that any of the other techniques are superior to what I do. And if there were a particular subset of a problem that I didn't do, I would send it to somebody who does it rather than try to do a procedure I don't do well. My personal preference is the infraclavicular. As I said, I developed a minimally invasive way of doing that that really causes very little tissue damage on the pec major muscle while we're getting in there, or a tubular-based approach to the pec minor tenotomy, which allows me to just pop a tube right down onto the cricoid process where the tendon inserts to cut it, once again, minimally invasively. So that, and then, as I said, I did an actual scalenectomy without first rib resection recently because that's all he had. He had no proximity, he had no reproduction with any of the other provocative movements, but had great response. So you have to tailor the treatment to the patient. You have to choose the surgeon that does a procedure well, but the particular procedure may be less important than the surgeon's skill with that procedure, as long as it's inclusive of the treating the symptoms that you're having. And that's a discussion also to be had with the surgeon to make sure that they understand what's going to go into, what's going to come out of the procedure they're doing, and that it's addressing adequately the symptoms you're having. And so it's more about how to choose the right surgeon than it is you shouldn't be choosing a checklist of technique. It should be the surgeon choosing which aspect that they're treating, and that they're choosing a procedure, a technique, and how they do it. Like, as I said, I do it with neuromonitoring to make it as safe as possible.
That's a good point.
Your mileage may vary. You also have to see the surgeons that you have access to, and how far you're willing to go to find them.
Yeah, so basically what it boils down to is there are surgeons who are really good at one technique because that's what they always do. And so that's part of the decision. If you do pick a technique, I guess, but that's not the patient's responsibility also. That's what you said. That third paper we discussed by Suzuki, Tate, if you want to contact us, we'll give you the link. It's pretty easy article to read about the different approaches if you want to understand what they are, how they're different. And thanks for the question.
Yep.
Cameron Harvey, I was wondering if there are any behavioral and or genetic factors that can increase the risk of developing TOS.
Well, I think we just mentioned hypermobility syndromes.
Like Ehlers-Danlos.
Marfan's, other types of hypermobility syndromes. But certainly, as far as behavior goes, as I said, sports that are high risk, like pitching, sports that involve a lot of upper body trauma, whether it be, as I said, swimming, and gymnastics and cheerleading. And cheerleading is often more of a traumatic issue, because while the cheers are going off great, they're either catching people, which is a lot of weight and trauma on the arms, or sometimes they're doing a handspring and they fall and they catch themselves. I see a lot of people with work-related injuries, and so I guess the behavior of working is considered potentially high risk. But as far as other genetic predisposing factors, people with other vascular disorders may be a risk factor. And that's pretty much any collagen vascular disorder certainly can predispose people to having TOS or TOS-like injuries. Scott seems to be having a technical challenge here. And so I'm going to go to the next question from Tate. What route of treatment is usually recommended for patients who show muscle atrophy in the Gilat sublunar hand? First, try to fix the underlying neurologic problem. so you have a chance of neurologic recovery. But then after that, it's just trying to strengthen the hand. And in some cases, in extreme cases, they have to do tendon transfers and releases if not just the atrophy, but contractures develop in the hand to try to regain function by transferring other muscles to the hand that's not working. And someday we may have bionic limbs that do the same thing, bionic implants that stimulate. Certainly functional electrical stimulation to try to get the muscles working again after a nerve injury has damaged it would be a precursor to trying to regenerate the hand. And that's something that's done a lot in physiatry, spinal cord injury rehab, and things like that. It's certainly a challenging process to try to treat. We'll go on to John. Dr. Jenkins, have you encountered any patients with upper cervical jugular venous compression in addition to TOS? And if so, did TOS surgery have any effect on jugular compression? John, funny you should ask that. That gets back into my CCI work that we've been doing. And I frequently see patients who develop a type of craniocervical instability that results in jugular venous traction, distension, occlusion, and essentially transient idiopathic intracranial hypertension type symptoms, brain fog, other cranial nerve anomalies that might be related to increased intracranial pressure, but also sympathetic dysfunction and autonomic dysfunction. And so we've been studying this and working with some other people trying to understand it better, looking at the vascular issues, the vascular substrate, and what we can do to make it better. In general, when I see somebody with both jugular venous compression and TOS, unless the TOS is really bad, jugular venous compression is a pretty serious situation, and we tend to treat that first. And so we tend to prioritize that evaluation and treatment above the treatment of TOS, unless it's ATOS, VTOS, or some other fairly considerate, significant, potentially acute problem.
Thanks, Art. I'm back. Can you see me?
I see you. Welcome back, Scott. We missed you.
All right. Thank you for taking over. You're a better moderator than me. You took all those questions perfectly. Hey,
well,
it's on the craniocervical instability in the jugular vein. That's a can of worms that, there's some evidence of venous congestion causing neuropathy, right?
Yes.
And so you're getting more into studying that now. That's really good news.
Yes, we are. And Scott, at some point, we may be talking about ways to better image. Similar to your arms up, arms down, we're talking about MR venography, head turned left, head turned right, head flexed, head extended. Obviously the coils that people use sometimes limit the ability to do those types of high resolution time of flight sequences, but certainly it's a wide open field if we can get some technology and some sequences that would really improve our understanding, and as well as kind of in many cases not just improve the understanding but prove what they have. So many of these patients have been told for years it's all in their head, and I keep trying to explain to the insurance companies, no, it's about 2 centimeters below their head.
I was actually just reading about, I had read a case where the jugular vein was compressed coming out of the skull, but it wasn't by the atlas and the styloid process. It was actually a little accessory muscle there that I had to research and find. And
I had a patient come to me with digastric muscle compression on her jugular vein.
Nice. I love those.
Not
They're
so
probably
nice
out
for
there
her,
and we just didn't see it.
It is a wild and woolly place. The craniocervical junction is a lot of high value real estate, and there's a lot the dynamic nature the impact each of these structures has on each other in this area under dynamic circumstances is not well understood. So there's an opportunity there.
Good. Well, hopefully I'll have the chance to continue working with you and discover new stuff at that. Thank you for your time again, Art.
Not too
I know
worried.
you visit us regularly, and you always make great contributions, and I know our viewers appreciate that. And you live in infamy because your videos are some of our most popular ones on our YouTube channel. So I'll remind people something I haven't said so far: smash that like button. Tell us you like us. That'll tell YouTube to keep showing us more and more people who need our. Thank you for the questions. Thank you for viewing. Dr. Jenkins can be reached, and you've seen his website listed along with a phone number. He's in New York City, Eastern Standard Time. We do have in 3 weeks a visit coming up with Vernon Williams, a sports neurologist from Cedars-Sinai. Really smart guy, really nice guy, very stimulating conversations like we have with the real Dr. J here. And I appreciate again everybody coming. And this is Dr. Scott Worden, the TOS guy, and we'll talk to you soon. Take care.
Take care, everybody. Have a good night. Be safe, be well.